a lot of discussion already have done on PD5 inhibitors comparison. The important is that sildenafil was first studied in clinical trials for coronary heart diseases in 1991. As realization of the market potential for oral PD5 inhibitors dawned, pharmaceutical companies set out to make new products and improvements. Different potencies, duration of action, and onset of action played into the creation of alternative PD5 inhibitor therapies. Here I mentioned leading 4 PD5 inhibitors as they are mainly available in the India. So with the year of FDA approval, first FDA approval was to the sildenafil in 1998, then tadalafil, vardenafil, and avenafil. Aim of the comparison is the treatment option should be tailored to patient and partner satisfaction, quality of life factors, and treatment-related safety and efficacy considerations. First, regarding efficacy. Effectiveness criteria were risk ratio of Global Assessment Questionnaire 1 score and mean difference in sexual encounter profile, that is SEP question 2 and 3. GAQ1 is improvement of erections, that is mean difference in International Index of Erectile Function domain. SEP2 is ability to insert, and SEP3 is successful completion of intercourse. As per efficacy, avenafil was associated with significantly lower GAQ1 response, that is relative risk, was 0.63. In the mean difference, that is MD assessment of SEP2, tadalafil and vardenafil were superior to sildenafil. Same on SEP3, tadalafil and vardenafil were also superior to sildenafil. In a rank of effectiveness analysis, tadalafil was most likely to be effective across domains, followed by vardenafil, as per Yuan et al. No significant differences in effectiveness and adverse effect in a review of 4 head-to-head PD5 inhibitor trials in another study. Now about safety was statistically similar between all. Higher incidence of myalgia with tadalafil versus sildenafil. Incidence of visual abnormalities with sildenafil and vardenafil are common. Nitroglycerin must be withheld at least 24 hours following the last dose of sildenafil or vardenafil and 48 hours following that of tadalafil and 12 hours following that of avenafil according to the drug variable half-life. Vardenafil may lengthen the QTC interval and must be used with caution or avoided in patients with prolonged QTC or those currently taking class 1 or 3 antiarrhythmics. The rate of side effects were the highest in the avenafil group. The risk ratio Sir, I think we are having some sounds. Please mute. And in comparison to placebo for any adverse event, highest with the avenafil and lowest with the sildenafil, equivalent to tadalafil and vardenafil, almost similar. Usual doses: sildenafil 25 to 100 mg per day, tadalafil 5 to 20 mg per day, vardenafil same, avenafil 50 to 200 mg per day. Regarding bioavailability, least bioavailability with vardenafil, that is only 15%, and highest with the sildenafil, that is 41%, almost equal to tadalafil and avenafil. Administration time before sexual activity. For sildenafil and vardenafil, it is 1 hour, tadalafil and avenafil 30 minutes. Time frame for efficacy. Avenafil is best known as emergency pill because of fastest acting. It is as early as 15 minutes. While sildenafil work for half hour to 4 hours, tadalafil up to 36 hours, means longest acting, and vardenafil for 5 to 7 hours. Plasma half-life, it is longest with the tadalafil 7.5 hours, while with others almost equal with the all others, sildenafil, vardenafil or avenafil. Now effect of fatty meals, as it was discussed in previous slides also. Cmax is the maximum concentration of drug and Tmax is time of occurrence of maximum drug concentration. Sildenafil is strictly not used with fatty meals because it increased Tmax by 29% and decreased Tmax by 1 hour and least affected by tadalafil. So it is safe after fatty meal. Vardenafil and avenafil may be used as they change Cmax by 10 to 20%. Renal adjustment, this is very important. It is dose dependence on creatinine clearance. If patient is taking sildenafil and if creatinine clearance is less than 30 ml per minute, then starting dose should be 25 milligram per day. In tadalafil, if creatinine clearance is between 30 to 50 ml per minute, then starting dose is 5 mg per day or maximum 10 mg 48 hours. But if creatinine clearance is less than 30 ml per minute or in patient is on hemodialysis, then maximum 5 mg in 72 hours. This is very important. And vardenafil doesn't use in hemodialysis patient. Don't use. Same with avenafil. Don't use in hemodialysis patient. So again, if the patient is on renal adjustment, sildenafil or tadalafil is better. As per cost, sildenafil is almost equivalent to vardenafil, but avenafil is costlier. Regarding tadalafil, it is economic in low dose but costly in higher dose. Patient preference. General preference for tadalafil based on longer duration of action because action up to 72 hours. Patients taking sildenafil or vardenafil were significantly more likely to switch prescriptions compared with those taking tadalafil. Of patients who switch from tadalafil, 20% patients switch back to tadalafil compared with a switchback rate of less than 10% in the sildenafil and vardenafil cohorts. Tadalafil is consistently preferred over sildenafil or vardenafil. Course may be taken with fatty food without disrupting viability, longer duration of action, and more spontaneity surrounding sexual activity. Avenafil comparative trials are lacking. Avenafil has been shown to have similar efficacy and safety consideration as the other three major PDE5 inhibitors. A unique benefit of avenafil, however, is its quick onset of action that counted as emergency pill. Cost is also an important consideration. Now, regarding conclusion, although multiple reports suggest general equivalency of efficacy and safety between the four major PDE5 inhibitors, tadalafil with optimal use has been suggested to be preferable, providing increased efficacy in the ability to insert and the successful completion of intercourse. Adverse effects, onset and duration of action, administration consideration, precaution and cost all are key factors in individualizing therapy. My dear friends, in webinar, we all are joining hands. So let's combat the stigma by talking openly about sexual relationships and related issues. Thank you. Thank you very much.